Welcome to an AJMC webinar. How will COVID-19 change telehealth and alternate payment models? I'm your host, Dr. Bruce Feinberg, Chief Medical Officer of Cardinal Health Specialty Solutions. Joining me today are three panelists with different perspectives on how the current pandemic is changing both telehealth and our ongoing efforts to make healthcare delivery more accountable. We have Dr. Kashyap Patel. He is the CEO of Carolina Blood and Cancer Care Associates in South Carolina, where he has developed protocols for using telemedicine to treat cancer patients in the time of COVID-19. He is also a national leader in implementing the oncology care model and is vice president of the Community Oncology Alliance. With him are Dr. Armando Salavanti. He is a primary care physician with the Commonwealth Health Physician Network in Old Forge, Pennsylvania, where he has seen a surge of telehealth visits in recent weeks. And lastly, we have David Terry. David is an MBA, and he is the CEO of Archway Health. And Archway is a complicated description. David, I'm actually going to break protocol, let you describe exactly what Archway does.
Great. Thanks, Bruce, and thanks for having me today. So Archway Health, we're a value-based care company. We provide care management support as well as financial underwriting, essentially stop-loss coverage for providers who are participating in value-based care programs of all types.
Thank you. Well, as a setup for what we're going to be talking about today, obviously it can be somewhat awkward in the current moment. Coronavirus disease 2019, COVID-19, caused by the SARS-CoV-2 virus, has reached pandemic proportions. It's pushing health systems to their limits. It's forcing CMS to relax regulations so that providers can treat patients and stay safe. But this newfound flexibility raises important questions. Will new services end with the resolution of the pandemic and the birth of the vaccine, even if patients find them very patient-centric and physicians too find them satisfying? Will years of progress towards quality and accountable care suffer? How to ensure quality care for patients in this unprecedented period? So in thinking about this, the panelists and I have had some discussions, and we believe there really are three acts to this storytelling. And Act One begins with an understanding of the technology behind telemedicine and telehealth and some of the accountable care programming that preceded it, but that addressed it in the design. And why was that adoption maybe not as robust as we might have thought, given much of our experience using FaceTime and other such apps in our everyday lives? In Act Two, what's changed in the pandemic? How quickly have providers been able to embrace this new technology, and how willing have payers been in supporting that use of the technology? Not only in terms of reimbursement, but also the risks of liability that exist and how well those encounters can be documented. And then in the third act is really this big question. Will these changes be long-lasting? Will, as different as life during the pandemic is in regard to healthcare, will life post-COVID-19 pandemic be equally as different and unrecognizable from what we knew for years prior to this development? So that's the summation of what we hope to cover today. We're going to begin by Act One, and I'll ask the panelists if they want to begin, and I'd like to get some conversation around just some background maybe to level set the audience. What exactly is telemedicine? How long has it been around? When was their first experience with it? What do they believe to be some of the issues related, and did they experience those issues as barriers? Whether it was reimbursement, whether it was risk and concern for liability and documentation, whether it was the inability to incorporate and integrate into their EMR workstream and daily workflow. So Armando, I'm going to let you kind of begin and maybe give us a little bit of background from your own experience with telemedicine.
From a family practice standpoint, especially in our practice, we had not used it before because of the lack of reimbursement locally in this area. It's become a necessity now, and patients have really taken to it. It's been well received, which I wasn't sure what was going to happen when we started to ask them about it. And many of our older patients who I thought would have some trouble with it have enlisted the help of their grown children to get them on the webcam or get them FaceTiming to a computer to help us out with it. But it's been very useful for people to cut their risk and still get the medical help that they need without having to come into the office.
So Armando, it's interesting. You say it's been very well received. And when I think about developments in a practice environment, there's always both how well is it received by the patients and how well is it received by the staff and physicians. So I assume your well received was really referencing patients, because I think it is a very patient-friendly and patient-centric. What about from the physicians and staff?
It's been great. We've been very much behind it because we weren't sure how to proceed with everything that's been going on. And we weren't sure what was going to happen as far as us being able to take care of our patients and meet their needs during this crazy time. And the whole staff has come together. Everyone has worked together to get this transition to be fairly seamless. I wasn't sure it would go off as well as it has. And
now,
we've been very...
No, go ahead, Armando. Finish your thought.
Yeah. And surprisingly, just to finish that up, it's been very vigorously received by the patients too. They're willing to come on. They're willing to understand what's going on and discuss everything that we need to over this kind of format. So it's been great.
Dr. Kashat, I know that you were it was kind of surprising to me because you were an early innovator in this area. And yet you're in an area of specialty medicine where I would think that most people would perceive it to be very much a direct, encounter environment where you really have to look at the facial responses, the body language. There's just so much involved in trying to deal with cancer diagnosis and management issues, as well as the fact that patients are coming in repeatedly for blood testing. And you would think, why would someone in oncology be early embracing it? When would they even use it?
Well, that's very interesting comment, Bruce, because you're right. In oncology, you want to feel, touch, sense, and kind of get all your five senses involved. But we need to be some realistic as well. So I have two locations. One is in suburban. The second one is a rural location. And my rural location serves patients who can drive up to 60 miles one way. So when we look at the Medicare population, where the telehealth program began initially, for a patient to drive 55 miles in a pickup truck who barely makes $1,500 a month to survive, he probably would end up spending probably $30, $40, $50 each time he would come and visit my clinic. So when we discussed this program to some of the patients who may have multiple comorbidities, but who may not have resources to go back to doctor's office back and forth, we said, would you be willing to work with us if we brought in this program and we would proactively reach out to you? And we always think of telehealth as something that, it's all video conferencing of Zoom or FaceTime. But our patient population do not even have the smartphone. They may not even have the cable connection. So there's a program called chronic care management where you identify patients at the risk of complications and being hospitalized for the want of attending to doctors. So we started with essentially implementing chronic care management program, and it became so well received by patients because we reach out to them every month, check if they've been to the ER, check if if they're in need of anything that could be addressed. A call from my office to a cardiologist would be a lot more effective compared to a patient trying to call their own cardiologist and get an appointment soon enough. So since 2015, we've been doing it. And then we took our foundation from the Robert Wood Johnson's pioneering study when they piloted a program in Northeast of proactively reaching out to patients with two or more chronic conditions, and found that they were able to substantially reduce the number of ER visits. And then I had privilege of talking personally to Barry Strobe, who actually designed the chronic care management telehealth program. And taking his word, we are able to substantially make investment and proactively start the program. So this was not something that was quite new to us, and we are way, way ahead of the curve. And our patients are happy. Our hospitalization rate has gone down. our patient experience has gone up a lot.
So I'm curious because your practice was also an OCM practice. And in a way, OCM facilitated your ability to do this, at least in that population, because you were now in a shared risk environment where you were assuming risk beyond just the immediate care. You were assuming risk for all cost that was involved. And so it almost seems like it was an investment that would be absorbed as a cost within your MIAS payment to do this. But were you doing this just in your Medicare patients who were part of the OCM, or were you doing this broadly across the entire practice?
So it started broadly across the entire patient population, and by now, I think 16 payers in our state are reimbursing for the chronic care management program. So we have almost about 1,500 patients on a chronic care management program, where we proactively reach out to them every month, and they're extremely happy. And coming back to Act 2, this has turned out to be extremely helpful for us to combat the COVID-19 induced stress and challenge on the system.
All right, so I got one more question before I give it to David, because I'd like to get some broader experience, especially with his knowledge of OCM. But I am curious, was there no concern about liability? I mean, I hear that voiced by physicians so often that, with my record with the patient not being physically in the office, and I'm making a recommendation to them, and something happens, and it could have happened regardless, but there would be that risk that because I didn't see them, I hadn't examined them that day, they did something that they either misinterpreted or would have happened regardless, that I would be at risk.
So that's very interesting. No, you make a very interesting comment, and what we've done is we've kept very low threshold of bringing patients back in. So out of every 10 calls, 2 patients end up coming to the office next day for the visit. So these and of those 2 patients, 1 underwent intervention. So 10% of the patients who are in the telehealth program at our clinic ended up coming on next day or same day visit, got hydration, got electrolyte infusion, got blood check, and they were able to get some sort of growth factors or IV antibiotics. So it really facilitated improving the patient care, reducing our concerns about the risk, because our threshold is very, very low. We tell patients that if you have slightest concern, don't wait, just come on over to the office on the same day appointment.
So David, with Archway's role as kind of an underwriter, do you have any direct influence on practices in terms of the types of programming they implement, since you're helping them within an OCM environment? And do you make recommendations regarding telemedicine, or do you engage in it at all in that regard?
Yeah, we do. So we are an underwriter in OCM. We work with a lot of OCM practices in providing analytics services and program support. We're a convener in the Bundle Payment for Care Improvement program, if you're familiar with that. So that means that we essentially are a care management partner, and we share risk in that program with providers. We underwrite ACOs who are participating in MSSP and NextGen programs. And so a big part of what we do is we help providers understand how they can move the needle, improve care for their patients, improve outcomes, reduce the total cost of care. And telemedicine has been a big part of that for us. There are various waivers in these programs that can allow for reimbursement. Frankly, we have not, up till now, done much with reimbursement for telehealth. We've done a lot with remote nurse services using both just the telephone as well as video support, more telephonic than video support, but have a lot of experience either on our own with our own teams, as well as with teams of care managers at provider organizations providing telephonic support for their patients most of our population that we work with are patients who are coming out of some sort of acute event or an exacerbation of a chronic illness. And so these are relatively high-risk Medicare patients, and our goal is to help them recover as quickly as possible, get home as quickly and safely as possible, and then provide check-ins while they're home so that we can identify who's at risk, who's okay and doing fine and recovering well, but also who's at risk and needs more support And then some of that support we can provide telephonically. And then some of that support, obviously, we need to bring patients back in to hopefully avoid an ER visit or readmission or something like that.
Dave, do we have any data that guides the benefits of telehealth? We've heard Armando mention, the patient centricity, and Kashyap talked about the fact that whether they may like it better, but it certainly is better for them. And and this is in a pre-COVID, because that excessive amount of travel, if they've got a lot of comorbid disease, or they're elderly, or they don't drive, or just the cost of doing so, losing a day of work, or an entire day of work instead of an hour or less of time. Do we have data that supports these benefits, that given the scale and scope of your work, that you've been able to apply in the modeling?
Yeah, so I can tell you about our experience. So our experience has been that through these interventions and paying closer attention through telehealth and other mechanisms to these patient populations, that we do see ER visits go down, readmissions go down, complications go down. So certainly have seen improvements in the outcomes and reduction in the cost of care using telehealth as well as other interventions. So I can't specifically, in kind of a double-blind study, point to the fact that it was telehealth that made the difference, but certainly engagement, more engagement with these populations. And engagement's expensive, right? So anything you can do that is improving engagement at a lower cost, I think is beneficial. There are studies that have been done. We were just actually on the phone earlier today with a telehealth company that was pointing us to studies that they put together and are citing that show that there is an impact in telehealth in terms of improving outcome, reducing costs. It's hard, as you know, to pinpoint any one thing that's driving that improvement, but I would say, just from a kind of anecdotal and common sense perspective, if Dr. Patel can get on the phone with his patients or on a video chat with his patients who are 60 miles away and engage with them on a much more regular basis, that experience is going to get better. The cost is going to go down because you're not touching them, spending a lot of money when you don't need to, and outcomes should improve.
So
Kashyap, before you go, I just want to make one comment. I wanted all of our audience to note my observation that the first reference to a randomized controlled blinded study was made by the MBA and not by the doctors. Just want to get that out. All right, Kashyap, you're on.
Sure. So Dave, just to kind of go back to your point, what we did was, we went for NCQA's patient-centered oncology medical home accreditation twice back-to-back with the commendation. And we had to show CQI, and we took what we call expanded access. We weaved in the chronic care management as a part of the expanded access, and we were able to quantify the number of patients who came to clinic. So we kept a separate visit called same-day appointment. So we're able to quantify 186 patients who came within 6 months and what intervention we did. And we took that quantification, assuming that if that patient went to ER after hours, what was an average expenses involved in that patient's case if they were going to ER and if they had neutropenic fevers. So we were able to indirectly quantify the saving to these our payers, and that also helped us get better negotiating power with the payers, as well as get our accreditation for the NCQA under the expanded access, which is one of the requirements that they have as a mandate.
Interesting.
And I think that's consistent with the experience in the Come Home demonstration. I'm sure, Dr. Patel, you're familiar with practices that participated in that program, right? So that was a big part of that was 24/7 triage opportunity, so that patients with cancer could call their practice, get access to their practice, and there was demonstrated outcomes there that showed that did reduce utilization of ER visits, which also in turn reduces utilization of hospitalization. So I think there is pretty good documentation that this can have a very big impact.
And for those tuning in, be aware the Come Home Project was the project that was created by Barb McEnany, funded by CMS for about $19.6 million for 5 years, to have 7 practices make significant modifications in their normal daily patient workflow. in order to see if they could improve quality at lower cost. But there were extended office hours and weekend office hours, and some other components that certainly contributed to that lower cost, not just the telemedicine aspect. But Dave, to your point, it is hard sometimes to do that analysis because there are multiple factors. So let's move ahead. And so we've addressed that kind of standing in this pre-environment. And what we learned about is that for practices that were engaged, whether in oncology or other, in an ACO, in an APM like the OCM, they may have been already embracing telehealth. But as Armando stated, if you were just in a routine environment, routine care environment, there were barriers, significant barriers to doing that. But that's changed dramatically in really just the last month to 2 months. And so where have those changes occurred? How quickly did payers change their willingness to accept and embrace? How have the physicians been able to change their workflow to incorporate telehealth? How have they been able to bill for those services? And so in this current environment, I want to take a look, and I want to go back to Armando, because as he spoke earlier, he had some pretty rapid, it sounds like a fairly rapid uptake. And I am curious if we can put some numbers to that. So, a year ago or even 6 months ago versus last week, percent of patients who were being engaged through telehealth, the types of patients and the types of disease management that can be done. And, where you think, how high can it go at its peak? Where do you think it may level out? But I'm curious, and I want to start with you regarding in this pandemic moment where we have this tremendous pressure to find new solutions for chronic patient management, what you've seen so far, and how long has it been going on?
Yes, as I said, we weren't doing any telemedicine visits, and now I would say it's occupying 90% of our visits in a day. There are routine things, some of these simple things that are coming through. Somebody has a rash to look at, or somebody has something else from a family practice perspective that you could easily see over the webcam. That's a very easy application. But where I think it's going are a lot of our patients that don't have transportation. We're pretty spread out as far as our practice is concerned. And we do have some people, as Dr. Patel said, coming from quite a ways, and it's made it easier for them to get in to see us. We're trying to do some disease management so we don't let people slip behind, even though we are having this problem with the pandemic. We don't want this to play negatively on people's disease states. So our diabetic patients, our hypertensive patients who have their blood pressure cuffs at home, they're checking their blood sugars, they're giving us updates on those kind of visits. And that's where I think it's going to be valuable, especially moving forward for some of these people that don't have the access.
So it's interesting. Go ahead, finish your thought.
No, that's okay. Go ahead.
All right. No, I was thinking, so you went to hypertension and diabetes, which I thought were going to be the sweet spots, because people can have their own sphygmomanometer at home, or they can be going to the local drugstore and checking it 3 times a week or whenever that frequency is. And obviously, the diabetics who are using any kind of glucose monitoring can have all that, keep the records, and be able to present that. That seems straightforward. But I was really surprised that you went to a rash as the first thing you mentioned, because that would have been, to me, one of those kinds of diagnoses. And of course, you've got to see it. You've got to be able to look at the entire body. You've got to be able to put on a glove and feel it. Is it raised? But anyway, it was very interesting because that's what I'm finding as I have more of these conversations, that it can be used in areas we wouldn't have thought necessary. The other thing that I'm observing— It does
scare me a little bit, Bruce. You know what? It does scare me a little bit. The rash, the thing to look at. It does scare me a little bit, but if we could help out, and at least in these times, it could make things a little bit easier. As an aside, since smartphones have become more available, for years, a friend or someone would call me up and say, "Hey, look at this. What do you think? My son came home with that." So we've sort of been doing a little bit of free telemedicine for a couple of years.
I think it's fascinating. Now, Kashyap, as I think about, again, oncology, where we're so dependent and maybe overly dependent on laboratory values and imaging and other factors. Again, that role of who those patients are, who fit into that paradigm. And the chronic disease management piece I get, but I'm curious about it extending beyond that. And I think about some of the recent data that's emerged that demonstrates that, is there a real benefit to an annual chest x-ray as part of just an annual physical? Is there a benefit even to that annual EKG? Baselines are valuable, but what's that value of that one point in time? And to some degree, it can be argued for blood work of a certain type and the frequency that is needed. And I'm wondering, to what extent, since you've had this long 5-year experience, have you started to rethink and retool what had been traditional surveillance pathways, which were never really tested, from the standpoint of that classical, randomized trial? We do things more out of habit than we do things out of science in many cases in medicine. So if you mind elaborating on that experience and expanding on what is that range of patient that's really appropriate?
Well, this is very interesting kind of point you bring up, Bruce, because our 5 years of experience, first of all, allowed us to see how do we shift our process during the COVID. The act number 2 is what we are talking right now. So, for example, looking at patients who are chronic lymphoproliferative disease like low-grade non-Hodgkin's lymphoma, who are just on a routine follow-up. Maybe we are just kind of, doing too much for them. I think we are trying to figure out the frequency that we can, spare apart so that we don't have to see them as often. And it came very handy for the COVID-19 pandemic, because we created 3 categories of patients based on our experience. One is where we need to pay significant attention. So we created category 1, which is top priority that we need to pay attention to, which is leukemics, diffuse large cell B-cell lymphomas, high-grade tumors, which could be anywhere from extensive small cell disease. In category low priority, we figured out patients with MGUS, patients with low-grade MDS, patients who have got stage 0 chronic lymphocytic leukemia. So we were able to, within a week's time, segregate the groups of patients to ensure that we did not expose low priority patients to come to the clinic and expose them to the risk of getting COVID-19 if somebody in my clinic was infected. So the knowledge that we acquired over the last 5 years helped me to categorize patients into low, intermediate, and top priority, and then see them accordingly. And I just wrote an article that's out in Targeted Oncology this week. It's actually online right now, of how does an oncology practice redesign, reallocate patients category so that we protect patients who don't have to be seen right away, that we pay attention to patients who need attention right away. And in the middle group of patients, for example, someone who's been on treatment for multiple myeloma, can we find all oral regimen for 1 or 2 months to ensure that these highly immunocompromised patients, we do not put them at risk while they're in very good partial remissions or maintenance therapy? So the knowledge came very handy for us to reshape the process in last 2 weeks.
And so again, it's only been the last few weeks. If you take that algorithm at its full implementation, what percent of a typical week's, what would have been a typical week's office patients would have been converted, do you think, to telehealth?
About 30%, a third of them.
Fascinating. So Dave, again, given the various partners you have, some of whom large institutional settings where they could have been doing this kind of analysis, are you seeing a level of telemedicine use that is as robust in any of them?
As robust as what Kasper just talked about?
Yeah, where it could be 30% of what would have been historical in office volume?
Yeah, so it's interesting. In the prep, some of the discussions were, is this how long has this been going on and been available and those types of things. I mean, I've been talking to telehealth companies since 2000. I mean, this is not a new industry. It's not a new space, but it hasn't caught on at all, really. And I think a lot of it is what Armando said, that, couldn't get paid for it, right? So there was only really one way to get paid: bring patients into your office and see them and provide services to them. And it just didn't, I'm sure Armando and Kashup's practices are very busy, and you can keep yourself busy by bringing patients in, and that's how you get paid. So what has changed, though, a couple of things have changed. One is the technology is just so much better and so much easier to use. I've literally personally had 2 telehealth visits just in the last couple of days. It's unbelievably easy. And I think what Armando is finding is it's also easy to implement from his side. And that wasn't necessarily true even a few years ago. There were certainly hurdles. We've made much more progress with security and the cloud and smartphones and ubiquitous laptops and tablets. And so the technology is just so much.
No blockchain yet?
I'm not going to say blockchain.
Right, because it doesn't seem you can have a conversation about effective technology anymore without invoking blockchain. Just wanted to be sure.
We don't even need blockchain to do this. It's so easy, right? So that's one. And then, but I would say most of the providers that we work with were not doing much in telehealth until 2 weeks ago. And now we have more than a dozen of our partners. I think it's well over a dozen who are implementing it as we speak. And I had a visit yesterday with a doctor. It was his second day of doing telehealth visits, and it seemed pretty natural for him and pretty natural for me. So I think there's been barriers to adoption. Reimbursement is one. Time and attention from the provider community is another. There hasn't been really a need to do it before now, because there's been plenty of demand for people to come to your office. But it is this crisis is certainly changing that, and changing that very, very rapidly.
Fascinating. So I'm curious, David, if you know how payers are approaching, not just from a standpoint of reimbursing, but often the patients would have a copay at the office visit. And are they invoking the copay when you do a telehealth visit? Do you know?
So I know what CMS has done. CMS essentially said there is a copay supposed to be part of the visit, but they're allowing providers to waive that copay during this crisis. Interestingly, in the visits that I've had personally, no one's asked me for money. So they figured out the technology, but they haven't figured out yet quite how to process the payment. And in this crisis, I think they're trying to just get through their day. I don't know, Armando, are you billing for your telehealth visits?
At this point, we have our central billing service that we we're leaving it up to them. So we do the visit, we send it in, and we let them decide at that point. So I haven't seen the downstream yet of this. We're worried, like you said, right now it's very new to me and to our group. So I think we're muddling our way through it a little bit, but hoping to take care of the patients first and figure some of this out later.
Kasha, you've been billing, right?
So we've been billing. I think CMS has come out with 2 codes. One is G2012, which is when the conversation initiated. The code from the intervention is anywhere from 99421 to 99423. These actually are 3 different levels of the code that a physician can put in based on intervention. Also, there are a couple of additional code downstream. One is if I ended up in talking to another consultant for the referral, I mean, there's a code that's extended. You can get up to $77. So depending on the visit as well as additional intervention, I could essentially have a substantial ROI if I had to devote more time than what it needed. So coming back to reimbursement, so Barry Straub, again, he was CMS director back in 2010 to 2014 when this program was implemented. And his frustration was that I brought in this program. They probably had about $40 billion plus allocated to this sort of telehealth and chronic care management. And for first 3 years, less than 1% doctors adopted. The CCM is the only program that CMS has increased reimbursement progressively to enhance the uptake, because as they saw that the physician groups that rapidly embraced and implemented the CCM program, they saw that their performance revealed that there were less number of hospitalization. And going forward to the value-based care, where all of us are going to be responsible for improving care, for reducing cost of care, for improving patient experience, there is no better program than telehealth and chronic care management that I could think of.
All right, that would be a good statement to close on, but we're not done yet. So we're going to move to the last act of our storytelling. And that last act really was focused on, given what we're hearing from our panelists and my observations over the last month or so, is that this looks like something which has been well received by patients in particular, but surprisingly well received by physicians as well. And the question then becomes, in the future, post-pandemic, is telehealth finally, as Dave said, he's been talking to companies who offer the service literally for 2 decades. Are we now at the point that as a result of the crisis and life return to a new normal, that in healthcare, telehealth is finally embedded firmly within the routine practice of medicine? So I'm going to let Armando go first, because you would think that in primary care, this would be the sweet spot.
I agree. In years past, in the winter months, when there's a threat of weather, we would lose a whole day. I mean, half of our schedule would cancel before we even got in there. And then all of a sudden there's not a snowflake. But if we could convert some of these people in advance over to some visits that would be telehealth, that would at least help us get through something like that. Because we are so spread out and the weather might be a little different where I am versus some of the other people where they're coming from. So I'm excited about that, not only because of the access it gives us, but also some of the things that we could cover on call. When, as an on-call physician, that will definitely help us out as well with the patient that may not be mine. And I don't know, just speaking to over the phone, I would be able to get more of a sense of what's going on for one of my cover partners if I could do telehealth medicine with them when I'm on call.
So Kashyap, you've already been doing it, so I'm not sure how much it changes. You offered the fact that it could be a third of the patients may be eligible for a telehealth-based surveillance, or comparing it in terms of a standard weekly. Is that where you think it lands in terms of whatever the new normal becomes?
I think it's going to go beyond that. So if you look into the new oncology care first model that CMMI plans to roll out pretty soon, I think unfortunately with COVID-19, it probably will be delayed. But patient-reported outcome, ePro, is going to be one of the essential components of the next alternate payment model. And having the remote patient monitoring, and I'm looking at companies that can include wearable devices. So if I have a patient who I need to kind of reach out to, high-risk patient with chemotherapy, to check on them and to see if I can monitor the temperature, their heart rate by wearable devices, the technology would eliminate a lot of in-person visits and also improve patient satisfaction. And I become more, as a part of oncology care model, we were involved in financial discussion with all the patients. It also brought me very close to patients' own financial worries. How much do they have to worry about gas coming to doctor's office? Even the patients who are on ongoing chemotherapy, if I can help them reduce the likelihood of visit by checking them on remotely, by having wearable device, I may get paid 20% less, but if it helps patient being financially more secure, I put it more in that perspective. And lastly, with the oncologists number shrinking, and then we both will have to continue to work longer, Bruce, compared to what I wanted to, because there's not enough workforce in the market really to fulfill the need of baby boomers. So I think to address the manpower shortage, to improve the quality of care, to reduce the patient financial toxicity, and to make me more efficient for focusing on where I have to see patient in person. This definitely will take on in a big way.
So Dave, I'm seeing you nod. I'm guessing that you would echo much of that, but I'm also curious, how does the technology advance outside of blockchain, of course, but how does that technology advance that could make it more effective? At what point, we're talking about wearables, would the patient at home be able to provide more data? To what extent does that laboratory piece, what is the minimum need to actually be seen live and touched by a physician? And I'm curious from your side, as you likely have done more sophisticated modeling, given the scope of work that you do, where do you think it goes and what's needed for it to advance?
Yeah, so a couple different thoughts. So first of all, none of this is going to replace the importance of having a relationship with a physician, whether it's a primary care physician or a specialist if you're sick and have some particular need. So that relationship and the ability to have someone who can see you and touch you and have a relationship with you is not going to go away. However, I do think the nature of those relationships is going to change dramatically and be facilitated in huge ways by technology, data, artificial intelligence, and all kinds of different things that are in the market today and continuing to grow. And just one kind of overall comment, this is obviously a crisis, a healthcare crisis that we're in, but it's a massive cultural event. And we're all realizing we can live our whole lives without leaving our house for weeks on end. And communicating with our colleagues and our families. I was at a virtual birthday party on Sunday. All our groceries and all our books and entertainment are coming without talking to anybody. And having to leave, get in our cars and get on the public transportation. So it's just changing the way we interact with the economy in so many ways that are, maybe partially predictable, but many, many unpredictable ways. And I think this is one of them, right? And I guess I would say, Bruce, the technology is not the barrier to adoption here, and it hasn't been the barrier for a number of years. The biggest barriers are reimbursement and present company excluded, the willingness of the provider community to adopt it. And that just changed. It just changed in 2 weeks. The provider community has now adopted it out of necessity in an unbelievably quick fashion. And the patient community, I think, really likes it and has wanted it for a while. So I do think it's here to stay. There's a lot to be worked out, including, how will people get reimbursed fairly for the time they put into this. But I think it's going to change the delivery of care in pretty big ways. I would see both Armando and Kashyap's panels expanding dramatically through this, because you can leverage yourselves more, you can rely on support teams more, you can rely on the technology more. Again, the question is how to get paid through that. But from where we sit as a care management partner and an underwriter, we're rapidly trying to identify where there are opportunities, who are the best technology players, who should we be partnering with, how do we change care models because of this. The OCM starts to do that. Primary Care First starts to think about, if you're going to do Primary Care First or OCM, you want to understand the financial implications for your practice and your business. Then you also have to figure out, how do you change your delivery model to succeed within those programs? And the best way is expand your panel, extend your capabilities, use different types of staff, and use technology. And this is a rapid accelerator for bringing those things to market.
Great summation. That was great, guys. I wanted to make sure, given the nature of the topic and how changing it is, that we left adequate time for Q&A. So let's do that now. Let's get some questions. I know many of you have been sending in questions over the course. If technology is working, I'm going to be having questions typed into my chat box, and I'll be able to read them. And so hopefully I'll be seeing one up in just a second here. All right. So it looks like there's one that addresses something that Kashyap dealt with, and that's in remote monitoring of cancer patients. Is it only those on active treatment? And you mentioned a lot of acronyms which may have not been picked up, like MGUS. And so if you could go in a little bit more, because it may not just be the patient that's on tamoxifen and has undergoing every 3-month office visits, where really you could be doing a lot of that, I'm assuming, through telehealth. But there are patients that oncologists see that are not on active treatment. So can you share a little bit more about that patient makeup is feasible for telehealth?
Sure. So there are a lot of other benign hematology patients that we see. For example, patients with low-grade, low blood count, for example, mild anemia or low platelet count, low white count. These patients may not present any acute emergency, but being aware that low blood count can cause sepsis or infection, these are the patients who probably are perfectly suited for remote patient monitoring, because I may not want to see them every time because they're at the risk of infection if they came to the clinic. But at the same time, if they're exhibiting signs of infection, it's that remote patient monitoring with wearable device which will help me to identify if I need to intervene. Same time, there are patients with low platelet count who may be on the low-dose prednisone or steroid or one of those newer agents, MAGs. If I put them on those medicines and if I want to space out their visit, they could be at home, talk to me. If they find, small rash, is it a rash? Is it bleeding under the skin? So all of this would be quite well monitored by remote patient monitoring without having to ask patient to come all the way to the clinic. So of course, not all the patients that are on remote patient monitoring have to be on chemotherapy or active treatment. They could be simply on surveillance for other reasons as well.
Would you ever consider starting a patient on a new treatment? Let's say that treatment would be a patient with minimally symptomatic advanced malignancy in which you had seen them, you were concerned based on maybe an exam finding or a blood test, and you decided to get an imaging report done, and then you decided that if that imaging showed there was progression, you'd put them on something like oral capecitabine, also referred to as Xeloda. Would you be comfortable discussing that with the patient over the phone and calling that prescription in and not doing it live?
No, that probably, I would reserve that to one-to-one discussion, because there are certain discussions I want to reserve one-to-one, which includes the going over the CAT scan report, going over the critical blood report, going over treatment changes, because you need that human touch. There's nothing more powerful than human touch that would help them a feeling of not being abandoned. I think telehealth has its place, but I think there's also necessity of one-to-one, face-to-face conversation with a human touch, and which what you just described is a situation that I would not resort to telehealth on those patients.
So Armando, you talked about, I was going to say, go ahead, Armando. I was going to have to call you anyway, because in primary care, there's also that question, what defines appropriate not? And, again, that patient that you'd meet and live and discuss the fact that we need to start a new blood pressure medicine, but the next 3, which would have been office visits, could be telehealth to see how they're doing with that medicine. Am I right there?
Absolutely. I was going to say the same thing. I think it's working very well with the patients that we've been seeing for quite some time and have a good rapport with. And I think that you couldn't totally take the telehealth route, but maybe the in-between visits. And we've spoken about that. There's certain people that, we have them coming in, especially with some of the things that we can do at home with the blood pressure monitoring, like you said, but having that relationship already embedded with the patient helps quite a bit. And that seems to be who will be most successful for in our practice.
Right. So I'm curious on 2 issues. One is the reimbursement question that we've addressed, but and Kashyap, you gave the most specificity about the billing codes. How do they compare to 99, 211 through 215 in terms of can you achieve relative parity, or because you're going to give up other income if they were coming to the office and there is laboratory, you would likely be doing it in the office. You might have your own analyzer. If you're going to do them telehealth, they might be going to, a LabCorp site or a local hospital. It saves them 50 miles, but it's also impacting, what would be normal revenue that be part of your environment that, you've built a model around. So I'm curious in terms of the reimbursement parity issue.
So that's a very interesting point you raise again. I think trying to balance between my interest of ensuring that my income is sustained and helping patient, survive on their monthly pay that they get from Medicare. So it's a very delicate balance. At the same time, in the world of the value-based care, whether I fall into oncology care first or whether I fall into the QPP track, I'm going to be responsible for patient experience, outcomes, and cost. If I'm not cautious about spending conservatively, then I may be vulnerable for 9% penalty based on the maximum penalty extent in QPP track. So either of the way, anybody with an NPI number will have to be accountable for reducing hospitalization, reducing ER visits, reducing unnecessary expenses. So I may be giving up a lot. So on E&M visit, your question is very right that I may be making 30-40% less than routine E&M in my clinic. But if I'm getting rewarded for efficiency, for quality, and for fiscal responsibility as a bonus, that could be 18% swing between me calling patients every day to my clinic and increasing my revenue versus working efficiently and getting rewarded by CMS 9% bonus.
So Dave, I'm hearing Cash App explain this, and there was never a greater incentive for moving the entire reimbursement model to a shared risk model, and yet we had pioneer ACOs and questions about what happens with the ACO movement. We had OCM, and it really stalled in being a risk model, became a bonus model. Now we're looking at V2, which would become the Care First model, which really is more of a risk shared model. But it begs that question: how do you move the entire healthcare system to a model that rewards for the best care, which likely right now for a doctor like Armando or Cash App is really a challenge, in a business environment, because you do want to keep your doors open. You're trying to preserve income for your staff, and this is the right thing to do. But
yeah, so a couple things. So one, I agree with Keshav. I think that if you're looking at sort of fee-for-service versus fee-for-service reimbursement, you're not going to replace what you're making through your office visit model and switching patients over to telehealth. It's just the reimbursement's lower, and you'll lose money that way, or your revenue will go down. So I think the practices that will be successful will change their business model if they want to move in this direction. Their panel size will increase, and they'll be in more programs like what we're talking about, where they can get rewarded for creating better outcomes and lowering the cost of care. And so then that gets to your question around where is the market headed with that in general. Before this crisis, we have lots of contact with CMS and Health and Human Services. What they were saying is, because of the state of the deficit and healthcare spending, they have no choice but to move Medicare beneficiaries into risk-based programs, whether it's Medicare Advantage plans or programs like NextGen, ACO, direct contracting, ACO, OCM, and those types of things. And what they've said is it's their goal to have 100% of providers in some sort of meaningful downside risk arrangement by 2025. Right now, they're at about 15%. So that's a massive shift of financial risk from the government into the private market. And so maybe they won't get to 100% by 2025, although the imperative to do that just increased dramatically last week with a $2 trillion stimulus that is yet to be paid for. So the need to shift in this direction is significant on the part of the government, and increasingly significant on the part of employers as we enter into what we think is going to be a recession here, and employers trying to figure out how to reduce these costs. So again, I think this is an accelerant for moving into more value-based type of models and creating incentives for folks like Keshup and Armando to change their practice in a fashion that enables them to, succeed financially in a different type of model.
Armando, a different track here, because I want to touch on more than with the limited amount of time we have left. But there is a question often comes up in many of these kinds of discussions. Is there anything that the biopharma manufacturers can do for the physicians who want to embrace this technology because they believe it's the right thing for their patients? And often when I talk to physicians, they're always left, I don't know. Is there anything you can think of, anything that will come to mind that you believe that the biopharma manufacturers can do to facilitate a more rapid adoption of what appears to be a very patient-centric approach to healthcare?
I think you bring up a great point, and I think there's so much more we can improve upon. There's many things as far as getting people to access. I think some of our barriers at this point have been the lack of access that people have to maybe smartphone or computer. It's not just the not knowing how to do it. It's the actual access to having the appropriate software or, rather than the ability to use it. So if we can make some of these things more widespread, whereas the insurance companies or somebody could outfit these people with maybe something simplistic even to allow them to do just the telehealth, that would be a big start, I would think. All
right. I love it. We had an idea. Dave, you smiled. Did you have an idea, or just laughing at the fact that it's tough?
No, I think that's a good idea. I also think, one of the biggest challenges in our healthcare system is alignment. And if we are shifting from fee-for-service to value, the more the device manufacturers and the pharmaceutical companies can show the value of their products in terms of long-term outcome and reducing costs, and how that will support providers and payers as they take on this risk. I think that can be helpful. We are seeing some contracts and product developments where, that with manufacturers assuming some of the risk for the outcomes and for the cost of the devices and the drugs that they're manufacturing. I think that would help as well.
Well, the questions are pouring in and the time is running out, what often happens. So I think we're at a point where we have to accept reality, as is often not the most pleasant thing, and as we're learning so often these days. And with that, recognize that it's time to close. So I personally just want to thank each of you for your willingness to do this. I think it's been great. I think this is an area, as Dave pointed out, decades of discussion, and to hear from a physician in a specialty you wouldn't have expected to be embracing it and have a 5-year experience, to talk to primary care that we would have thought would have been doing it, but the barriers were too great, but now is, and understand the real depth, breadth, and scope of this solution for so many patients, and really for overall in healthcare for cost, but yet the barriers that still exist and limit them. So once again, my thanks, Dr. Keshup Patel, Armando Salavanti, and David Turry for joining us today, and for all of you for participating and sending in your questions. And with that, I'll say goodbye.
Thank you.
Thank you.
Thank you.